Okay, thank you, Rachel, for the introduction. So today, Dr. Resciniti and myself are going to be sharing about the Maternal Morbidity and Mortality Review Committee update. I am going to start with some of the processes that the committee does. Dr. Resciniti will talk about the data from the 2025 legislative brief, and then I'm going to follow up with recommendations and contributing factors. And then we're going to have a case presentation at the end, and we hope that you will participate in that. Next slide. So this is our why slide about why we're doing what we're doing. This picture was taken from an article in the Charleston Post and Courier in April of 2024. This mom did pass away a couple days after she birthed her baby here. And you can access that article. It's pretty it's pretty enlightening, and it talks about this woman's mom gives her story. So I encourage you to look that article up. Next slide, please. So the Maternal Mortality Review Committee is legislative mandated. It's a statewide committee with a multidisciplinary membership. Currently, there are 31 active members. There are about 60% clinical members and about 40% community members. The committee also has a team at the Department of Public Health that are very dedicated, and all of the committee would not be possible without their dedication. The scope of the committee is a maternal death, a woman who dies during pregnancy or within 365 days, regardless of the cause. The committee has 3 goals: to identify the number of pregnancy-related deaths, to identify trends and risk factors, and then make actionable recommendations for prevention of future deaths. And the vision is to eliminate preventable pregnancy-related deaths, reduce maternal morbidities, and improve population for women of reproductive age in South Carolina. Every March 1st, the committee publishes a legislative brief, and Dr. Resciniti will share the data from the 2025 brief with you shortly. Last fall, the Department of Public Health was awarded a cooperative agreement by the CDC, and this grant focuses on getting timely data out on data implementation and timely reviews. Next slide, please. So I just wanted to review a few key definitions that the committee uses. Pregnancy-associated death is the global term for a woman who dies during pregnancy up to 1 year. And then that term is kind of divided into 2 different tiers: a pregnancy-related death, which occurs from a complication of pregnancy, a chain of events that's initiated by the pregnancy, or an aggravation of an unrelated condition by the physiologic effects of pregnancy. And then a pregnancy-associated death that's not related is more that the woman died, it was more like circumstantial or happenstance that she died. It was more like a coincidence. So if you look at the tree over on the right, you can see the pregnancy-associated death is all of the tree, and then the orange is the pregnancy-related deaths. There's a smaller portion of pregnancy-related death regarded to the global pregnancy-associated deaths. You can go to the next slide. So this is a data slide. This is the only data slide that I have. The committee has completed 4 cohort years, with the last being in 2021. The committee has identified 88 pregnancy-associated deaths. Out of that 88, 27 were pregnancy-related. So the committee goes through a standardized process for each death. Each death that's reviewed, the committee goes through and asks 6 key questions. And this is based off guidelines from the CDC. The South Carolina Maternal Mortality Committee follows the best practices and gold standards that are put forth by the CDC. So the questions that the committee asks are: was the death pregnancy related? What was the cause of death? Was the death preventable? Identifying the critical contributing factors. The committee makes recommendations and for actions to address those contributing factors, and then looks at the anticipated impact of those actions if implemented. So I wanted to show you a little bit and to be a little transparent with some of the processes that occur during the committee meetings, because the committee and the Department of Public Health, we get a lot of questions regarding different sections of the legislative brief and how that data was determined. So I wanted to share with you here, this is like a little snippet of the form that the committee uses. And this one is addressing pregnancy relatedness. So the really big question is for each death is, was the death pregnancy related? And oftentimes the committee will ask, if she had not been pregnant, would she have died? To help make that determination. So this slide's pretty complicated, but it's pretty, I realize the print is pretty small, but one of the areas that sometimes is a very gray area for evaluating pregnancy relatedness is sometimes the substance use disorder deaths and women who die by suicide. So this is a tool that was created by the CDC, and the committee uses this tool when those causes of death have been identified to help standardize and determine relatedness. And if anybody wants this sent after, I'd be happy to send it out. So when the committee is looking at the cause of death, it's not necessarily correlating with the cause of death that's found on the woman's death certificate. It's really was what's the underlying cause, what initiated and what started the chain of events that ultimately led to her death. And the committee will identify the cause, and then if you go to the next slide, there are codes that the committee uses to help identify which type of death this is and which classification it is. You can go to the next slide. So this is the circumstances surrounding the death. This area probably gets the most amount of questions. So for each death, the committee determines if obesity, discrimination, mental health conditions, or substance use disorder contributed to the death. And it wasn't necessarily if the woman had that, was it a contributing factor? If the committee answers yes or probably for any of these questions, those are the variables that kind of are reported out in the legislative brief. So I wanted to, if you could go to the next slide, I wanted to focus a little bit about the determination on discrimination, because a lot of questions are focused around this, especially with the higher number of Black women dying. So when the committee looks at this determination of discrimination, they're using the Smedley and Dr. Rachel Hardman definition for discrimination, which is over here on the right side. And it really talks about discrimination based on groups, classes, or categories of people that result in biases and prejudice. So the committee has identified discrimination that occur with a woman's age, her weight, a medical diagnosis or a condition such as substance use disorder or a mental health condition, or race. So when the committee selects discrimination, it can be for any one of those categories. Oftentimes, when we're talking about discrimination and we're talking about if race was a factor, the family interviews are really helpful in determining that. So when the committee is looking at discrimination and racism, there's that arcing discrimination contributing factor. If the committee decides that race was a factor, it then can be broken down into one of two categories. Interpersonal racism, which really is kind of focusing on interactions of people, versus structural racism, which focuses more on systems and historical injustices. So I want to go to the next slide that's very busy and it's really small, but this also comes from the CDC, and it's really a helpful tool for the committee to determine interpersonal and structural racism if it was present. So in the middle, you can see the forms of racism, and then on the right side, you can see manifestations in healthcare. So when we look at interpersonal racism, we are looking for maybe complaints that were ignored or not addressed. If she had some issues of, let me think here, like improperly, maybe that she wasn't given a referral. I can't even hardly read that small print. And for structural racism, one of the things that the committee does identify is lack of transportation to prenatal appointments. That is listed as one of the factors for structural racism. So if interpersonal structural racism is identified, these do affect racial inequities in maternal mortality. So I want to address the question about preventability. One of the questions that's asked was this death preventable? And it's a yes/no question. And when the committee is determining preventability, it's really focusing on, would there be some chance to alter the outcome? If something was done differently, would she still be alive? So when the committee is looking at this for preventability, and there's probably a lot of clinical people on the call today. And when we think of, oh, the death was preventable, we often think of maybe it was a clinical assessment or a care coordination issue. But when the committee is looking at preventability, they are looking for, this isn't like a facility M&M board. They're really looking at prevention from various different levels. So there are 5 levels of prevention. If there could have been a change, or there could have been something done differently for any one of these levels, not just at the provider level, but at the patient and family, the facility, systems, or community level, if there could have been something different with any of these, then the death would be determined to be preventable, and recommendations would be made for the preventable deaths. So I'm going to turn this part over to Dr. Resciniti, and then I'll be back to talk about contributing factors and recommendations.
Hey, everybody. It's great to be on the call, and appreciate everybody's time listening to what Kim had to say. It's very informative, and the data related to it. And just want to give a shout out to Kim, her team, all the abstractors, and everybody on the committee that make the decisions, collect the data, import the data, so that my team and I can analyze it and be able to share it with the legislators, but also the community as well. It's a lot of hard work that goes into it. So I just want to acknowledge everybody's hard work in that. As I go through these slides, I just want to acknowledge one thing first is COVID was impactful for many areas, but in relation to this data specifically, we saw our first COVID-related mortality in this population in 2021. And that, as well as all the other COVID-related deaths, impacted the data and shifted it in some ways that we'll see throughout the presentation. So just keep that in a frame of mind on if you have your last brief present and you're comparing, because I know I always have that handy, you'll see some slight differences. So I just want to acknowledge that before anything happened. So this is the first slide, and we could see that this is looking at South Carolina pregnancy-related mortality rate from 2018 and 21 compared to the U.S. average. We could see that we're consistently higher than the U.S. average, but it fluctuates from 2018 to 2021 on which year is the highest. But as we could see here in 2021, it's 47.2 deaths per every 100,000 live births, which was the highest. One thing to note, again, related to COVID, if we were to take out all COVID-related deaths, which is not a fair comparison, because counterfactually, the individuals could have died from other things, so it could have raised it or been somewhere in the middle of this. If we were to take out those deaths, the rate would be about 27 per 100 live births. So that's how impactful COVID was within this year. So when we're looking at how pregnancy-related mortality rate is calculated, I just want to show how the sausage is made. I know that I'm a data person, so I understand this, but I just want to show to everybody how everything happens to calculate the rate. So if we take 2021, for instance, we can see that the abstractors and everybody on the committee reviewed 88 cases. Of those, 27 were deemed pregnancy-related deaths. So we take that number, divide it by the live births, which in 2021 was 57,179. So we get that number and we times it by 100,000. 100,000 is just kind of an arbitrary number just to make it a whole round number for statistical purposes and just making it easy to interpret. So we get the whole number that for every 100,000 live births, we can expect 47.2 pregnancy-related deaths. Next slide, please. So this is from the legislative brief specifically. We're looking at the trends over time by race and ethnicity. We'll see in the next slide, but this is the first year that we had enough data to report on Hispanic deaths. However, we can't do that from year to year because the data is too small, but we can report it over the 4-year period, which we'll do next. But we could see here that from 2018 to 2021, for those that are non-Hispanic Blacks, the pregnancy-related mortality increased from 40.5 to 71.7. But we could see that from 2018 to 2020, there's actually a decrease from 27.6 to 19.2 for non-Hispanic white individuals. However, during the year that we had experienced some COVID deaths, it increased from 19.2 to 36.9, which was the highest over that 4-year period. Over that 3-year period from 2018 to 2020, we could see that the disparity between the two increased from 1.5 to 3.7. So there was an increasing disparity between those that are non-Hispanic white and non-Hispanic Black. However, it appeared to decrease to 1.9 in 2021, but that wasn't done by any interventions. It was mainly because those that were non-Hispanic white experienced increase in death. So it's good to peel back the layer sometimes and look why something may be increasing or decreasing and try to address that. It appeared that it might be good, but in actuality, it's just because that non-Hispanic white woman died more frequently that year, unfortunately. Next slide, please. Thank you. So this is, again, like I said, looking at those the race and ethnicity. Again, this is the first year that we had those that are Hispanic. Non-Hispanic white and Hispanics had similar rates, but was still about half as less as non-Hispanic whites over that 4-year period. So interesting data, and again, something that we look into and address as we go through this report. So these are leading causes of pregnancy-related deaths. Again, this is over a 4-year period, and I told you to think about how COVID was impactful in this. So this data is from a 4-year window, although we only saw COVID-related deaths within 2021. Even though data for COVID was only in 2021, it still accounted for almost 14%, which was the leading cause of death over that 4-year period. So is very impactful in these numbers as presented here. So overall infections, which was COVID-related deaths, and also mainly sepsis, that was accounted for about 25% of all deaths over that 4-year period. But if you compare this to the previous years of data, infections was actually about 4 or 5. in the last report, while the others were in the same order, with mental health conditions / substance use disorder, embolisms, cardiomyopathy being the other top leading causes. If we look at this based upon race and ethnicity, those that are non-Hispanic white, if we look at, we take out infection again, the top two leading causes were mental health conditions and substance use disorder and hemorrhaging, which was different than those that are non-Hispanic Black women, which were embolisms and heart conditions. Again, a significant difference and something that we need to look into further. Next slide, please. Thank you. This is circumstances of pregnancy-related death. Kim touched on this a little bit previously, and this is a hot topic every year. If we compare this to last year's chart, discrimination was about a third of all pregnancy related to a third of all pregnancy-related deaths, while obesity was less than that, about 25%. So these numbers flip actually from last year to this year. So obesity is the number one circumstance related of pregnancy-related deaths, while discrimination is second. I won't read the text there, but basically discrimination was recognized as the contributing factor in almost 1/3 of the pregnancy-related deaths. So when we look at timing, again, this is another thing that was impacted compared to previous years of data. I think last year's of data, as you can see in the last bullet point, about 33% of all deaths occurred between 43 and 365 days. Now that's about 26.4%. The majority shifted to 7 to 42%, or 77 to 42% of days, that's 28.7. So that's the majority of deaths within the related to when someone was pregnant or not. And again, the majority of the reason was a lot of COVID-related deaths were during this time. Again, this is something that Kim talked about, and we're looking at preventability of pregnancy-related deaths. We could see here that from 2018 to 2021, it fluctuated a little bit, but all of these data are similar to the national average. So we know that we're about there with them as well. Here's a map of rural versus urban counties. The whole state is shaded. Just one caveat related to this is not all counties had a pregnancy-related death. This is an extrapolation of the data that we did have to all rural and urban counties. So just one thing to note, but comparing rural and urban areas, we could see that rural areas had about a 60% increased risk of pregnancy-related mortality compared to the urban areas. I think this is one of my last slides, if not my last slide, but we could see here this is pregnancy-related mortality by age, and similar to last year's report, we could see that as the age group increases, so does the pregnancy-related mortality. And I think that might be my last slide. We'll go to the next one, please. Yep, I think that is Kim now. Thank you, everybody.
Thank you, Nick. So this is a pyramid that is reflecting how data can fuel action. When we look at the top of the pyramid, we see the pregnancy-related deaths, kind of with a cascade down about severe maternal morbidity, getting maternal health complications requiring rehospitalization. We often get asked, like, why doesn't the committee study maternal morbidity? And we take the guidance from the CDC saying that if you make recommendations that are appropriate and for improving maternal health, we should see all the other areas. It should have a cascading down effect, and all the other areas should also be improved. So when we look at the recommendations that are made in the brief, the 2025 brief, a lot of the data is collated between like 18 to 21, but the recommendations are only for the 2021 deaths, and they are done on a qualitative analysis. And even though each death is given recommendations, like on the individual case or the individual death, what is done is we look for repetitive themes among all the deaths. And when repetitive themes emerge, those are the recommendations that make it into the brief. We also include the contributing factors. This year, addressed in the brief is 3 disproportionately affected populations, which are Black women, women who reside in a rural county, and also women with substance use disorder and or mental health conditions. So the committee looks at 28 contributing factors, and these contributing factors are what are used to make the recommendations. So when the recommendations are made, sometimes these exact words aren't in the recommendations, but a synonym might be used for them. So if you are familiar with last year's brief and previous year's briefs, the recommendations were actually listed out by contributing factors. This year, to really put the emphasis on that it is not just the contributing factors, but it is levels of prevention, the decision was made to do the recommendations based on prevention level. So the 5 levels are listed out, and then with recommendations made under each level. I'm not going to read each one of them, but I did just want to touch on at the systems level. We are looking at like access to care, ability to pay, which is finance, looking at discrimination and respectful care, also looking at case management, care coordination, along with substance use disorder and mental health conditions. At the facility level, policies and procedures regarding maternal safety bundles were addressed, some screenings, and again, substance use disorder. There is one recommendation, and it's the last one under this facility level, that is getting national attention regarding emergency room physicians and personnel getting training about the appropriate care of pregnant and postpartum women. So I do want to point this one out. This is like a national recommendation. At the provider level, we do see the impact of COVID-19 with treatment and the vaccination and treatment for COVID-19. And then again, about screening and referrals for substance use disorder and mental health conditions. Kind of rounding things out at the community level, there is like knowledge deficit regarding outreach and education about the urgent maternal warning signs, and also about substance use disorder resources that are available to pregnant and postpartum women. And at the patient and family level, it is like adherence or to the COVID-19 vaccination, or recommendations for women, pregnant women, to be vaccinated. So, and that completes this part of our presentation. Here's our contact information. We'll be happy to address any questions that you have. I see there are some questions in the chat.